Met me before. I'm Patrick Ramsey. I'm a maternal fetal medicine provider down in San Antonio at the University of Texas Health program with the University Health System. I'm also the chair-elect for the collaborative and been here during the whole process as this has evolved for us to kind of ramp up this conference, as well as working as an implementation partner with Texas AIM. And very excited to have Barbara O'Brien here for this session, because about 3.5 years ago, we had Barbara come up to our collaborative meeting, and we were meeting with DSHS and trying to talk about how do we bring AIM into Texas and become Texas AIM, and have the collaborative work with that to push the effort forward. So our session now is going to be talking about the AIM Hypertension Bundle, which, as you've heard during the course of the last 2 days, is our next bundle that will be implemented in Texas. The TCHMB will be the implementation arm of that effort as that moves forward. They're planning to have a launch sometime in early June, and those dates will be coming. So I'm proud to introduce Barbara O'Brien. She is Director of the Office of Perinatal Quality Improvement at Ohio University. Oklahoma.
A different
yeah, right. So the Ohio State, no. Oklahoma University. And I've been there before, so Oklahoma University, thank you for correcting me. Health Science Center, College of Medicine. Barbara began her career as an RN in labor and delivery 33 years ago and has 17 years of experience as director of the Office of Perinatal Quality Improvement within Oklahoma University Health Science Center, College of Medicine. This office leads the work for Oklahoma Perinatal Quality Improvement Collaborative, providing education and perinatal care to perinatal care clinicians in leading quality improvement activities within Oklahoma birthing hospitals to advance the vision of a culture of safety and excellence in perinatal centers throughout Oklahoma. She is an active member of AWAN and serves as the National AWAN Representative to the Council on Patient Safety and Women's Health Care. Please join me in welcoming Barbara O'Brien.
Thank you so much, Dr. Ramsey. I'm always excited to come to Texas. I grew up in Texas. I spent my childhood in El Paso and then moved to Houston. Went to nursing school at UT Houston, and my first job as a nurse was at, I think now it's Memorial Hermann. Back then it was Hermann Hospital. I had an internship and then became a labor and delivery nurse there, and then moved in the summer of 1986 to Norman, Oklahoma for my husband to finish college then, and we were going to move 1 year to go to Oklahoma with our plans of coming back to Texas. That was 34 years ago. We love Norman, Oklahoma, so I am from the state to the north, and always excited, as I said, to come back to Texas. So thank you for having me. So our Oklahoma Perinatal Quality Improvement Collaborative has been around a little bit longer. Oklahoma was the first AIM state, so we began this work 4 years ago in 2016. So I'm going to talk a little bit about our journey. Our vision in so we're going to talk, what would I have wanted to know before we began the Hypertension Bundle Implementation? So that's what I'm going to focus on in my talk today. When I think about the objectives, I'm not going to go into all of these here in depth, but applying the QI principles and then identifying potential barriers and what are some strategies to mitigate these potential harms with these barriers. So our vision, as we said, creating a culture of excellent safety and equity in perinatal care. And what our vision is that no matter where a woman gives birth in Oklahoma, she will receive care that is safe, of excellent quality, and equitable. So we work with all the birthing hospitals in the state and nurses and doctors to put forth this vision. I really like this statement here: perfection is not attainable, but if we chase perfection, we can catch excellence. When you interact as a patient in the healthcare system, you're assuming, I think, our patients assume they're going to receive excellent care. We owe that to them. That's our duty, to provide excellent care. I always think of that commercial for AT&T, okay is not okay. Just okay is not okay when we're talking about health care. So we need to achieve excellence. I invite all of you all to come visit us. We're about 6 hours north on I-35. This is our Health Sciences Center campus in Oklahoma City. And our Norman campus, this is where I live, just a couple blocks away from the University of Oklahoma. So come give us a visit anytime. I received my bachelor's degree from University of Texas. I received my master's degree from University of Oklahoma. I am, we talk about football, I am an OU fan. I stayed here in the hotel, and like they had this bathrobe with the Longhorn on it. I was like, I'm not gonna wear that. So, but I am here with all of you because what's really exciting to me as we go forth with this work is how all of our states are working together. And I'm sure you all feel that your hospitals are working together. And even at the national level, through the National Network of Perinatal Quality Collaboratives, all of our collaboratives are working together. So I do feel like, we are working for that standard of excellence. So just a little bit of background. I know Oklahoma and Texas have some similar qualities. Some of the things are different. Mainly, you are really big. So we have 48 birthing hospitals in Oklahoma. I know you have 200. I know you have 215 AIM hospitals. You have 220-something birthing hospitals, so that's a lot more than we have. So I know how you're working in regions and trying to accomplish that. But thinking a little bit about our rural presentation earlier, 58% of those hospitals are located in a rural location, and 42% are located in an urban location. But when you look at our births, we have about 50,000 annual births in Oklahoma, and that flips. So, I like to think of it about 2/3 are located in rural, 1/3 are located in urban, but about 2/3 of the births occur in an urban hospital, and 1/3 of the births occur in a rural hospital. As you can see, our volume of births ranges. Our smallest hospital has about 30 annual births. Last year, they were actually down to 16. And our largest are about 4,100 annual births. And about 58% of our births in Oklahoma are covered by Medicaid. So that's where we are coming from. This is a map of our hospitals in 2020. Currently, our birthing hospitals. We have 77 counties in Oklahoma, and 50 of them do not have a birthing hospital. Notice the Panhandle is bare now. This is our map from 10 years ago. We have decreased our birthing hospitals by 14 in the last 10 years in Oklahoma. So I know that you all are feeling similar effects here. So enough about who we are. Let's talk about Hypertension Bundle. So what do you need to know before you begin? Why are we doing this first? And you all have seen lots of data. I too am aware of all of the things that are in the media. Some of the headlines: the last person you'd expect to die in childbirth. This was a NICU nurse in New Jersey, and her husband is an orthopedic surgeon. She complained of headaches and had one-sided paralysis. Her nurse told her that was probably a result of the morphine. Morphine doesn't give you paralysis on one side of your body. It doesn't make sense. So use your critical thinking here. If you hemorrhage, don't clean up. Advice from mothers who almost died. So bring proof. Make sure they know how much you bled. For every woman who dies in childbirth in the U.S., 70 more come close. Those are those 50,000 women every year who experience severe maternal morbidity. U.S. has the worst rate of maternal deaths in the developed world. That's pretty sobering. U.S. hospitals struggle to protect mothers when childbirth turns deadly. Hospitals know how to protect mothers, they just aren't doing it. Ooh, that sounds pretty damning. And then hospitals blame moms when childbirth goes wrong. Secret data suggests it's not that simple. And then, of course, we have the disparities associated with our maternal mortality and morbidity crisis, where in Oklahoma we have about 11% of our births are to Native American women. They also have a 3 to 4 times higher risk of experiencing death or severe maternal morbidity. So some of the more recent headlines, just in the last couple of weeks, you know that the U.S. released its first maternal mortality rate since 2007. So I always think we value what we measure what we value. And we didn't have a U.S. rate for more than 10 years. A soaring maternal mortality rate, what does it mean for you? Yeah, my daughter is pregnant right now, due in May. It's like, I feel like, I have this skewed perception, I know too much. The rising U.S. maternal mortality rate demands action from employers. We finally have a U.S. maternal mortality estimate. It's still terrible. So we haven't done very good in this. And then just last week, when women die in childbirth, these are the fathers left behind. So I want to always focus on the patients. And remember, when we talk about data, this is a woman who lost her life, a husband who now often goes home to care for a newborn alone. Nobody thinks that's going to happen to them in this day and age in the United States. So thinking about these families that are affected. And this is the maternal mortality rates that were just released. In the United States, the rate was 17.4 per 100,000 live births. Oklahoma is the 4th worst. Only Arkansas, sorry, Dr. Lowry, and Alabama and Kentucky are worse. Ours is 30.1. We have about 15 deaths per year. And this recent publication from June, when we talk about hypertension, this is what I want all of you all to get from this. The reason women die because of hypertension is because they're having strokes. Their blood pressure is higher, and it's usually the systolic reading greater than 160. So we need to pay attention to these numbers. I think that we tend to normalize some of these things because our population is generally healthy, and so we don't get worried about this, but we need to move in that direction. So this it was in the Green Journal back in June. So these women are dying from stroke because of systolic hypertension. So why are we doing this? Well, Dr. Shields was just here. He's one of the authors of this, Hypertension in Pregnancy. This tells us we need to treat our severe hypertension with an antihypertensive medication. Here's some other ACOG practice bulletin. This is from a year ago, gestational hypertension and preeclampsia. Emergent therapy, also back from January for acute onset severe hypertension during pregnancy and the postpartum period. Treat your hypertension within 30 minutes. And then start MAG. So these are some things that are out there. The National Partnership for Maternal Safety, this is a little bit older, from 2016. And then again, this is from last year. I'll talk more, but one of the questions we get a lot is, well, she has chronic hypertension. This still says, if she has a severe hypertension reading, you need to treat the blood pressure. It doesn't matter what's causing it, you need to treat it. I think most of you are aware of this, but where is all of this coming from? Just to make sure everybody knows where all of this work started, on the Council on Patient Safety and Women's Healthcare, and that was developed in 2015 in response to all of these concerning data. This group is represented by all of the professional organizations who care for women. And I have the privilege of representing A1. So council develops the bundles, then the Alliance for Innovation in Maternal Health, or AIM, is the implementation arm for these maternal safety bundles. So why are we having problems? Why is this an issue when we come to your hospital and we want you to implement a maternal safety bundle? And when we talk about quality improvement, because we have to change. And when we look at this, you must learn to embrace change. Can we change anything we want to change? No, you don't get to say what the changes are. I do that. Will that situation ever change? No. Why not? You said change is good. Change is good for other people, so embrace it or I'll fire you. We love change, right? So oftentimes you don't have a lot of choice in this and what's going to happen. But I would argue that these maternal safety bundles are there to improve outcomes and to standardize that care that we give, which is all about what we're all about. Want to make sure you all are aware of the Council on Patient Safety and Women's Healthcare website, safehealthcareforeverywoman.org. And this is where the safety bundles reside and the main AIM website. So I would encourage you to go explore this website. There are a lot of different tools on there for you. So one of the things when you go to your hospital and you're implementing QI, and I'm glad to sit at your QI person here, quality improvement can be, it's a change in how we do things. So one of the things that we created is a guide for implementing quality improvement projects. So this is housed on the council website and goes into the processes that you will take back to your hospital to implement quality improvement. You can't just say, okay, we're going to start treating severe hypertension. We're going to implement the hypertension bundle. There's a lot of steps to this process. So this is a tool for you to use to look more into what is that quality improvement process and are we using this in our hospital. Another thing that's very helpful on this website are the safety action series. So all of the toolkits, all of the bundles that are released, they have an hour-long webinar on that bundle where the experts are presenting. So these are all archived. They're there. You can go back and look at them. It's something that you can use in your education with your nurses, with your doctors. When you talk about education is one of the things you'll measure. Well, these are the things that are available for you, having people listen to one of these safety action series. And then I also would encourage you to visit our website. It's not just for Oklahoma, but we've been doing this now for a few years, so we have a lot of different resources for you as a hospital to use as you are implementing this hypertension bundle. So our main page is opqic.org, and we have an AIM page. One of the things that I think is really helpful, I was at a meeting it was actually this week on Tuesday, and the physicians at this meeting, this was at a hospital, who was having some problems with physician engagement. And they said, how do we get our physicians to do the education? You know, it says you're supposed to put in as a process measure what percentage of your nurses, what percentage of your physicians have taken this education. And, you know, we already know this stuff. So, yeah, why do I need to do some kind of education? And I talked about, well, some hospitals use this for credentialing, but then later in the meeting, one of the nurses talked about how many of their physicians are not using antihypertensive treatment they are just giving magnesium sulfate. And it's like, okay, so this demonstrates you do need this education. So we all need to be educated. I don't think it's harmful for anybody to go and read something or take an hour to listen to the Safety Action Series. On this page, we have listed a whole lot. There are AIM e-modules that you can listen to and get a certificate when you complete it. So yes, we all need to be on the same page. We all need to be educated. And this here, I want to point out, Dr. Shields is one of the doctors on this webcast. So AIM made this way back in 2016 when we started, and Dr. Shields and Dr. Martin and Dr. Drusen are on this webcast. They are the authors of the Hypertension in Pregnancy publication. And they talk in this, it's about 20 minutes, about the AIM bundle for hypertension and treating severe hypertension. So I would encourage you to have everybody listen to this webcast because they talk about the severe hypertension as a critical blood pressure reading. We need to use those words. It triggers in our head that this is serious. This is a critical blood pressure reading, and this is a hypertensive crisis. So in other parts of medicine, they think about hypertensive crisis. We don't think of it in that way in our head, and we often hesitate to act. So this is one page with AIM resources. Another thing there is when you're looking for all of the publications that come out and all of the research studies, it's hard for you as nurses and doctors that are busy clinicians to find that. Where did I read this? What has come out lately? So we have that here, Hemorrhage Bundle Implementation, Research and Resources. Hypertension Bundle Implementation, Research and Resources. So all those things that I just showed you, you can find them here on our website. And if you can't access, you can email me and I will send it to you. So these kinds of resources we have there to help you try to make things easier. And then we have another on the other side of this page where we talk about the bundle, where we've broken it into the 4 R's, and then what are the different resources that you can use for each one of these R's as you are implementing your hypertension bundle. So these kinds of resources like recognition, we created a PDF that you can copy. How do you take a blood pressure? That's the first step. You have to have an accurate blood pressure. I know that goes back to the very beginning of nursing school for many of you, or medical school, but that's critical in this bundle. You have to have an accurate blood pressure. So all of these kinds of tools are there and available for you. So here's our strategic planners planning meeting. Once you go back to your hospitals and you got your team together, and then you got to start having meetings, which we all love to have meetings, especially like this one, right? So the agenda today is, before we set the agenda, we need to determine our goals for this meeting. Before we set the goals, we need to map out our care strategy for determining them. First, we should plan a strategy for strategically planning our planning process to determine our goals. Does that sound like some of the meetings you go to? So, you need to meet frequently with your team to set deadlines. That's what I think the meetings do. They make you have a deadline, so you're held accountable for getting your work done. And one of the things that we created back on the previous page, for all of the bundles, we created a worksheet for every single thing in the bundle. So this works in our hospital. We already have this. No, we don't have it. This is what we need to do to change. This is who's going to be responsible, and this is our target date. So you can use those in your meetings to plan and ensure that your goals are being met. So what's different about this hypertension bundle? You've already implemented hemorrhage, which is pretty complex. And that's got a lot more moving parts than the hypertension bundle. But when we look at our readiness and our recognition and prevention, this is the actual bundle on the website and all the different steps for this, and the response and reporting. The main challenges, the barriers that we have seen are this one for your notification, taking your blood pressure, notifying the provider, and that you are treating that within 30 to 60 minutes. Okay, so that's our biggest barrier, is getting that severe hypertension reading treated. And so when I think of the barriers, the main thing that we're not doing is taking it seriously and following through, like Dr. Shields was just talking about with our early warning signs even, and following through and treating that blood pressure. So this has been the main barrier for us in Oklahoma. Now, when we look at our data, so this is our process measure, we show, and ignore that very first data point that I whited out because somebody went in and put in data before we actually started. So we were starting at about 60%. That's pretty high. Some of our hospitals had already been working on this. But notice how we had a decrease. And I'll talk about that in a minute. That's because once we got better at collecting the data, we showed that we were not treating these at the rate we thought we were. So that, we'll talk in a minute, because that's the other hard thing about this bundle is the data collection. So our rates actually went down, and then we went up and to where now we're about hovering around the low 80s. Yeah, I think we should be higher than that. I don't know why we can't get higher than 80% for treating hypertension, but that has been a 54% increase since Q4 2015. So why don't we treat the severe hypertension? And you've probably seen this from Dr. Main. It's the denial and delay. Women die because they do not receive early, effective, and aggressive life-saving treatments. We had a case just recently on our maternal mortality review of a woman who died from a stroke from severe hypertension. She was postpartum. She came back into the hospital. They sent her home. She had come back into her doctors. They sent her home, and then she died at her home. So this still happens. You know, I just wanted to cry. Like, can we fix this? This is a family now that they've lost their mother. The significant other has lost his partner, a child without a mother. So this is why women are dying. We are not acting. So this is our mantra in Oklahoma. Believe it and treat it. We tend to not believe the blood pressure readings. Do y'all see that? You take the blood pressure, oh, well, yeah, she's hurting. She's stressed. She and her husband just got in a fight. She has chronic hypertension. So we're not believing that this is a critical value. I don't care what causes this. I don't care if she stood on her head for 30 minutes prior to your taking her blood pressure and now it's severe. She's at risk for stroke. No matter what is causing it, she is at risk for stroke because she has a severe hypertension reading. There is something pathologically wrong here. So we need to treat it and we need to investigate what's happening. We've seen when we started this, you talked about, somebody mentioned a postpartum woman coming in from an outpatient setting. And they talk about, well, we treated it and then it got better and so we sent her home. If a woman is having severe hypertension and, have your accurate blood pressure reading, that's your first step, and still having that, and you're having to treat that, it's probably not okay to just, okay, we decreased your blood pressure, now you can go home. We used to do that in triage all the time when I was a nurse, a young nurse, and they'd come in with a severe reading, and we'd put them on their left side, and we'd take it again, and then we'd take it again, and we'd take it again, until it got to be something that we liked, and then we sent them home. So believe it and treat it. That's your mantra. Believe your blood pressure, treat it within, I would say, 30 minutes if possible. So this is 3 easy steps, really. It's not as complicated as the hemorrhage bundle. Take the accurate blood pressure. Now, accurate is the key. I've had, but we took the blood pressure when she was pushing. That's not a time that you should be taking blood pressures, right? That's not going to give me an accurate blood pressure reading. So ideally, she's sitting up and she's got the appropriate size cuff, and, she's got her feet on the floor, and that's not going to happen in the labor setting. We can't have that ideal situation, but we need to get there as close as possible, as much as we can. Consider the clinical context. Again, don't take it when she's pushing. Making sure that you are looking at the patient. If she's coming in and she's complaining of headache, and some of these women, they're obviously sick, it's like, okay, we need to act quickly. This is a critical situation here. Verify within 15 minutes, okay, because we get errant readings on our blood pressures sometimes, so make sure that this is accurate, and then obtain the order to initiate a protocol. So I like having a standardized protocol for your hospital, that we are all doing the same thing. Sometimes that can be hard to agree on. Gain your IV access. We've had situations, if it's hard to gain IV access, you can always fall back on nifedipine, doing your immediately release nifedipine. And some providers are using that as their frontline drug because it's easier. You can just do that very quickly. So which protocol would you like me to initiate? Have medications available on the unit. This was something that a lot of our units had to do. They didn't have all these medications in their Pyxis. So they would have to call pharmacy, for especially the nifedipine. They may not have that. So make sure that these are all available within your Pyxis. And then if severe, treat within 30 to 60 minutes, 30 minutes if possible. That's pretty easy, right? Initiate the protocol, and then again, the one standard protocol that this is a hypertensive crisis. Have that in your head. Everybody agrees. I know you guys at Texas AIM have done the team steps thing also. We have hospitals, and I think it works really well for them, that they initiate a huddle whenever there's a severe hypertension reading. So they have a huddle, so everybody knows this is going on with the patient, and that everybody's aware, and are we decreasing the blood pressure? They're taking this seriously to ensure that this is being addressed. And listen to the patient. Again, always, what else are her complaints? Use that critical thinking to put that picture together. The treatment of the severe hypertension is your first priority, and then starting MAG if that's appropriate for this patient. And that was one of our big barriers when we started, was that a lot of hospitals were not giving antihypertensive medications at all. They were just giving the women magnesium sulfate. Said, oh, well, we use MAG. Magnesium sulfate is not an antihypertensive agent. It's for seizure prophylaxis, okay? So give your antihypertensive and then your MAG. And I already mentioned that. Potential other bumps in the road. Chronic hypertension. On the AIM data measure, it excludes these women when you're gathering your data. So some people thought, well, we don't have to treat them. It could be a little more nuanced, your treatment for the women that have chronic hypertension, but they still should receive treatment if they have severe hypertension. And then again, the outpatient setting. What happens if they get a severe hypertension in an outpatient clinic? They should come over and we're treating them, and you don't discharge them just because you get the blood pressure to go down after giving one dose of labetalol or something. I mentioned the difficulty obtaining IV access to notify the provider. And sometimes, I know we've had this happen with the provider thought that this had been done and it never had been given because they still were trying to get an IV in. Oops. And then working with your emergency departments. This has been really helpful. We also are participating in the A1 post-birth warning signs. So ensuring that women are educated when they're discharged, and a lot of these women, especially in the postpartum setting, are gonna present to your emergency department. Their parameters for severe hypertension are different. For regular adults, it's like 180, so you need to educate emergency room personnel that this is our protocol. So our protocol should be present throughout the hospital. And then transferring those women to the OB unit unless the clinical situation necessitates she remain in ED. And then also the postpartum. When I was a nurse, began as a nurse, we said delivery of the placenta cures preeclampsia. So we never diagnosed women with preeclampsia if they were postpartum. We weren't paying attention to these blood pressures. Okay, the other big issue is the data reporting. So this is the hardest thing, I think, for hypertension for these women as well, is identifying the patients. So I want to give you a few hints here. You can use an EMR query. We do have on our website some people in Epic and others that have put their query on there and what they've done in their hospital. So that's one way, but you're going to get a lot of, if you just try to search for severe hypertension, there's a whole lot of readings that you're going to get that are not the patients that you're looking at. This is the first time they have their elevated blood pressure. You're not measuring for every time they have an elevated blood pressure. It's the first one, was it treated? Looking at your pharmacy records can be helpful. So who received these medications? And that's a way that you can identify those patients. Then you see if they got treated within 1 hour. And then if you are using an EMR query, you can eliminate these because you've already looked at them. So it kind of dwindles down your patients that you would be searching for in your query. You can also use your Pyxis to see who had these medications pulled, and a delivery log. Putting in a column for this so that you can identify that these women had severe hypertension. I like the real-time data collection. That if you have huddles, every time you have this, you're going to know which patients have severe hypertension. But this is relying on that nurse who takes the blood pressure to do something about it, because that's the first step of potential failure, is when the nurse does not follow through with that severe hypertension reading. But having that huddle or the charge nurse at the end, some of our hospitals have a log where they write down, this was the patient, this was the blood pressure, and she was treated within this amount of time. So that's an easier way to do it than trying to go back for a quarter and find these patients. And hopefully, if you're doing real-time data collection, you're also treating the patient, because you're not going to have a patient that you have a severe reading and then, oh, well, we're not going to do anything about it. So that can be helpful as well. And I don't know, you guys may have identified other ways too. This This is one of the hardest things for this bundle, is identifying the patients. And the other key thing is to make sure that the coding, that you are identifying these patients properly with proper documentation and coding. So getting your physicians and coders, getting everybody together to talk about this so that they have an understanding of what each other are doing is a good thing to do. I would be remiss if I didn't talk about women and families. So I spoke to Nicole Perinatal is here. Nicole, so she's got some resources from the Preeclampsia Foundation I'll show you here in a minute. And what do women who have experienced this situation, how are we failing them? First of all, we need to educate them. So if we are educating them on these symptoms, then when they come to us and complain of these symptoms, we need to follow through and investigate. So do your duty to figure out what's going on when these women complain about symptoms. The other thing, if you look here, the black ones are those that are in the bundle. So they say we're not diagnosing accurately and quickly enough. And these are women in their experience. This is what happened to them. Their blood pressure was not treated. Their severe high blood pressure was not treated. Their expectant management, they were managed where they felt like they were delivered too soon once they found out after all this happened what's supposed to happen in these women. Things happen too quickly or too late. And then educating them about monitoring postpartum preeclampsia when they've, especially, have a diagnosis and are discharged. The other thing that they talk about here that I think is important, the preconception early pregnancy risk assessment for these women with a history of preeclampsia or without a history of preeclampsia, the prenatal patient education and aspirin prophylaxis guidance. I think it's going to get to where every woman practically is going to be receiving aspirin. Postpartum PSD. A lot of these women suffer. You've heard from Leah yesterday about mental health issues after experiencing a traumatic birth. And then having a care plan for the long-term effects. They do have long-term risks, these women with a diagnosis of preeclampsia. And then getting women on your team so you can hear their voice and listen to these mothers or their support partners. Here are the toolkits that are available. These are at no cost to you, and the only cost is shipping. So you can go to the preeclampsia.org, and then there's also a video. We have this on our website as well. This is a really short video that providers could show to all of their women. 7 symptoms every pregnant woman should know. I think our community needs to know so that all of us know how to support these women. So these are tools that are available to you now. This one about the future risk is an infographic, and if y'all are interested, any providers, in getting this as a tear pad, they can produce it in that way. So overall, looking at our data in Oklahoma, we've reduced our severe maternal morbidity among all delivering women by 22%, working through AIM. So, that's pretty exciting. And I think I'm excited to have Texas joining this effort. I am here to help. We are not there I'm not going to turn somebody away because they're not from Oklahoma. So use our website. Feel free to contact me if you have questions, and good luck with your hypertension bundle.
So we have time for maybe one question, and then we'll break for lunch. If not, you can meet Ms. O'Brien up here at the stage and ask any questions you have. Anybody have any questions? All right, we'll break for lunch, and then we'll return here at 1:15.